Welcome to you and your friends. I am Nguyen Thieu, born in 1942 in Hanoi, working in military medicine since 1960. I am the younger brother of the late Minister of Health to Vietnam, Professor Dr. Nguyen.
Bringing in my bloodstream of traditional healers who specialize in stroke patients at home, I was heartbroken to see more and more people with cancer. To see the level of danger, cause and prevention of this cancer, I created this channel to share with you and all of you. We sincerely hope you and your friends, after watching this video, click subscribe and like to support the channel and share this video for many people to watch. Thank you and your friends. Hope you and your friends regularly visit and support my channel. I wish you good health and happiness. After 4 years of cancer treatment, I have normal health is thanks to the Qigong of Vietnam. Right now I just want to have more friends to share. I am very happy to meet you. Here is my channel. I look forward to your comments. I wish you and your whole family a healthy, lucky life. Coronary artery disease.
CAD as of 2010 was the leading cause of death globally, resulting in over 7 million deaths. This is up from 5.2 million deaths in 1990. In 2015, Canadian dollars affected 110 million people and resulted in 8.9 million deaths. It makes up 15.9% of all deaths, making it the most common cause of death globally. The risk of death from CAD for a given age has decreased between 1980 and 2010, especially in developed countries. The number of cases of CAD for a given age has also decreased between 1990 and 2010. In the United States in 2010, about 20% of those over 65 had CAD, while it was present in 7% of those 45 to 64. And 1.3% of those 18 to 45. Rates are higher among men than women of a given age. Coronary heart disease, CHD, is the leading cause of death for both men and women and accounts for approximately 600,000 deaths in the United States every year. According to present trends in the United States, half of healthy 40-year-old men will develop CAD in the future, and 1 in 3 healthy 40-year-old women. It is the most common reason for death of men and women over 20 years of age in the United States. It is estimated that 60% of the world's cardiovascular disease burden will occur in the South Asian subcontinent, despite only accounting for 20% of the world's population. This may be secondary to a combination of genetic predisposition and environmental factors. Organizations such as the Indian Heart Association are working with the World Heart Federation to raise awareness about this issue. Coronary artery disease, CAD, also known as ischemic heart disease, IHD, is a group of diseases that includes stable angina, unstable angina, myocardial infarction, and sudden cardiac death. It is within the group of cardiovascular diseases of which it is the most common type. A common symptom is chest pain or discomfort which may travel into the shoulder, arm, back, neck, or jaw. Occasionally it may feel like heartburn. Usually symptoms occur with exercise or emotional stress, last less than a few minutes, and get better with rest. Shortness of breath may also occur and sometimes no symptoms are present. The first sign is occasionally a heart attack. Other complications include heart failure or an irregular heartbeat. Risk factors include high blood pressure, smoking, diabetes, lack of exercise, obesity, high blood cholesterol. poor diet, and excessive alcohol, among others. Other risks include depression. The underlying mechanism involves atherosclerosis of the arteries of the heart. A number of tests may help with diagnoses including electrocardiogram, cardiac stress testing, coronary computed tomographic angiography, and coronary angiogram, among others. Prevention. Up to 90% of cardiovascular disease may be preventable if established risk factors are avoided. Prevention is by eating a healthy diet. A diet high in fruits and vegetables decreases the risk of cardiovascular disease and death. Vegetarians have a lower risk of heart disease, possibly due to their greater consumption of fruits and vegetables. Evidence also suggests that the Mediterranean diet and a high-fiber diet lower the risk. The consumption of trans fat, commonly found in hydrogenated products such as margarine, has been shown to cause a precursor to atherosclerosis and increase the risk of coronary artery disease. Evidence does not support a beneficial role for omega-3 fatty acid supplementation in preventing cardiovascular disease, including myocardial infarction and sudden cardiac death. There is tentative evidence that intake of menaquinone, vitamin K2, but not phylloquinone, vitamin K1, may reduce the risk of CAD mortality. Regular exercise. Aerobic exercise, like walking, jogging, or swimming, can reduce the risk of mortality from coronary artery disease. Aerobic exercise can help decrease blood pressure and the amount of blood cholesterol, LDL, over time. It also increases HDL cholesterol, which is considered as good cholesterol. Separate to the question of the benefits of exercise, it is unclear whether doctors should spend time counseling patients to exercise. The U.S. Preventive Services Task Force found insufficient evidence to recommend that doctors counsel patients on exercise, but it did not review the evidence for the effectiveness of physical activity to reduce chronic disease, morbidity and mortality. It only examined the effectiveness of the counseling itself. The American Heart Association, based on a non-systematic review, recommends that doctors counsel patients on exercise. Medications and exercise are roughly equally effective. High levels of physical activity reduce the risk of coronary artery disease by about 25%. Maintaining a healthy weight, decreasing obesity, and not smoking. The World Health Organization, WHO, recommends low to moderate alcohol intake to reduce risk of coronary artery disease. Decrease psychosocial stress. Sometimes medication for diabetes. In diabetes mellitus, there is little evidence that very tight blood sugar control improves cardiac risk, although improved sugar control appears to decrease other problems like kidney failure and blindness. High cholesterol, or high blood pressure, are also used. There is limited evidence for screening people who are at low risk and do not have symptoms. Treatment involves the same measures as prevention. Additional medications such as antiplatelets including aspirin, beta blockers, or nitroglycerin may be recommended. Procedures such as percutaneous coronary intervention, PCI, or coronary artery bypass surgery, CABG, may be used in severe disease. In those with stable CAD, it is unclear if PCI or CABG, in addition to the other treatments, improve life expectancy or decreases heart attack risk. Signs and symptoms. Chest pain that occurs regularly with activity, after reading, or at other predictable times is termed stable angina and is associated with narrowings of the arteries of the heart. Angina that changes in intensity, character or frequency is termed unstable. Unstable angina may precede myocardial infarction. In adults who go to the emergency department with an unclear cause of pain, about 30% have pain due to coronary artery disease. Pathophysiology. Limitation of blood flow to the heart causes ischemia, cell starvation secondary to a lack of oxygen, of the myocardial cells. Myocardial cells may die from lack of oxygen, and this is called a myocardial infarction, commonly called a heart attack. It leads to heart muscle damage, heart muscle death, and later myocardial scarring without heart muscle regrowth. Chronic high-grade stenosis of the coronary arteries can induce transient ischemia, which leads to the induction of a ventricular arrhythmia, which may terminate into ventricular fibrillation leading to death. Typically, coronary artery disease occurs when part of the smooth, elastic lining inside a coronary artery, the arteries that supply blood to the heart muscle, develops atherosclerosis. With atherosclerosis, the artery's lining becomes hardened, stiffened, and swollen with calcium deposits, fatty deposits, and abnormal inflammatory cells, to form a plaque. Deposits of calcium phosphates, hydroxyapatites, in the muscular layer of the blood vessels appear to play not only a significant role in stiffening arteries but also for the induction of an early phase of coronary arteriosclerosis. This can be seen in a so-called metastatic mechanism of calciphylaxis as it occurs in chronic kidney disease and hemodialysis, Rayner-Liedtke 2008. Although these patients suffer from a kidney dysfunction, almost 50% of them die due to coronary artery disease. Plaques can be thought of as large pimples that protrude into the channel of an artery, causing a partial obstruction to blood flow. Patients with coronary artery disease might have just one or two plaques, or might have dozens distributed throughout their coronary arteries. A more severe form is chronic total occlusion, CTO, when a coronary artery is completely obstructed for more than 3 months. Cardiac syndrome X is a term that describes chest pain, angina pectoris, and chest discomfort in people who do not show signs of blockages in the larger coronary arteries of their hearts when an angiogram, coronary angiogram, is being performed. The exact cause of cardiac syndrome X is unknown. One explanation is microvascular dysfunction. For reasons that are not well known, women are more likely than men to have it. However, hormones and other risk factors unique to women may play a role. Diagnosis. For symptomatic patients, stress echocardiography can be used to make a diagnosis for obstructive coronary artery disease. The use of echocardiography, stress cardiac imaging, and/or advanced non-invasive imaging is not recommended on individuals who are exhibiting no symptoms and are otherwise at low risk for developing coronary disease. The diagnosis of cardiac syndrome X, the rare coronary artery disease that is more common in women, as mentioned, an exclusion diagnosis. Therefore, usually the same tests are used as in any patient with a suspicion of coronary artery disease. Baseline electrocardiography, ECG. Exercise ECG-stress test, exercise radioisotope test, nuclear stress test, myocardial scintigraphy, echocardiography, including stress echocardiography, coronary angiography, intravascular ultrasound, magnetic resonance imaging, MRI. The diagnosis of coronary disease underlying particular symptoms depends largely on the nature of the symptoms. The first investigation is an electrocardiogram, ECG/EKG, both for stable angina and acute coronary syndrome. An X-ray of the chest and blood tests may be performed. Stable angina. In stable angina, chest pain with typical features occurring at predictable levels of exertion, various forms of cardiac stress tests may be used to induce both symptoms and detect changes by way of electrocardiography, using an ECG, echocardiography, using ultrasound of the heart, or scintigraphy, using uptake of radionuclide by the heart muscle. If part of the heart seems to receive an insufficient blood supply, coronary angiography may be used to identify stenosis of the coronary arteries and suitability for angioplasty or bypass surgery. Acute coronary syndrome. Diagnosis of acute coronary syndrome generally takes place in the emergency department, where ECGs may be performed sequentially to identify evolving changes, indicating ongoing damage to the heart muscle. Diagnosis is clear-cut if ECGs show elevation of the ST segment, which in the context of severe typical chest pain is strongly indicative of an acute myocardial infarction, MI. This is termed a STEMI, ST elevation MI, and is treated as an emergency with either urgent coronary angiography and percutaneous coronary intervention, angioplasty with or without stent insertion, or with thrombolysis, clot buster medication, whichever is available. In the absence of ST segment elevation, heart damage is detected by cardiac markers, blood tests that identify heart muscle damage. If there is evidence of damage, infarction, the chest pain is attributed to a non-ST elevation MI, STEMI. If there is no evidence of damage, the term unstable angina is used. This process usually necessitates admission to hospital, and close observation on a coronary care unit for possible complications, such as cardiac arrhythmias, irregularities in the heart rate. Depending on the risk assessment, stress testing or angiography may be used to identify and treat coronary artery disease in patients who have had an STEMI or unstable angina. Risk assessment. There are various risk assessment systems for determining the risk of coronary artery disease, with various emphasis on different variables above. A notable example is Framingham score, used in the Framingham Heart Study. It is mainly based on age, gender, diabetes, total cholesterol, HDL cholesterol, tobacco smoking and systolic blood pressure. Medications. Statins, which reduce cholesterol, reduce risk of coronary disease. Nitroglycerin, calcium channel blockers and R-beta blockers. Citation needed. It is recommended that blood pressure typically be reduced to less than 140/90ths of a millimeter of mercury. 81. The diastolic blood pressure, however, should not be lower than 60 millimeters of mercury. Beta blockers are recommended first line for this use. Antiplatelet drugs such as aspirin. In those with no other heart problems, aspirin decreases the risk of a myocardial infarction in men but not women and increases the risk of bleeding, most of which is from the stomach. It does not affect the overall risk of death in either men or women. It is thus only recommended in adults who are at increased risk for coronary artery disease, where increased risk is defined as men older than 90 years of age, postmenopausal women, and younger persons with risk factors for coronary artery disease, for example, hypertension, diabetes, or smoking, are at increased risk for heart disease and may wish to consider aspirin therapy. More specifically, high-risk persons are those with a 5-year risk greater than or equal to 3%. Antiplatelet therapy. Clopidogrel plus aspirin reduces cardiovascular events more than aspirin alone in those with an STEMI. In others at high risk but not having an acute event, the evidence is weak. Specifically, its use does not change the risk of death in this group. In those who have had a stent, more than 12 months of clopidogrel plus aspirin does not affect the risk of death. Surgery. Revascularization for acute coronary syndrome has a mortality benefit. Revascularization for stable ischemic heart disease does not appear to have benefits over medical therapy alone. In those with disease in more than one artery, coronary artery bypass grafts appear better than percutaneous coronary interventions. Newer aortic or no-touch off-pump coronary artery revascularization techniques have shown reduced postoperative stroke rate comparable to percutaneous coronary intervention.
God says, heart peaceful, world peaceful. Buddha said, 100,000 Dhamma are born by heart. 100,000 Dhamma are killed by heart. The word Dhamma, Sanskrit, Dharma, is meaning to uphold or to support. It is upholds or supports the practitioner of Dhamma, and prevents him or her from falling into evil states or birth in a woeful existence. This question applies to illness, which means that despite the illness, but still calm mentality, not worried panic. Shen is stored by the peace in the heart, thanks to peaceful sleep, dreamless. In short, we must create a lifestyle, a schedule of work and rest, recompense, respire, and to meditate and Dian Shen Dan, hyperthermia, increased hemoglobin, increased blood pressure, reduce pain, sedation, sleep well. Using drugs to help keep Jing, practicing breathing to help nourish Qi, but Shen is stored does not exist so easy. If still Jing, still Qi, but lost all Shen, then while still alive but living plant life, living is like death. Thank you so much. See you next time. Please click subscribe and like to support channel.